Hi everybody. We thank you for hopefully you're all going to watch our video. Today is International Scoliosis Awareness Day, as everybody knows, especially if you have scoliosis. Today I have Pat Kiley, surgeon, pediatric surgeon, and we decided to bring Niamh McGowan, who's a spinal physiotherapist, with us today to have a chat. We got some of the questions in that both can kind of cover, so we thought it was a great idea to have two experts today to help you. So first of all, thank you Niamh and Pat for joining us today on Saturday morning. I'd just like to say, first of all, we have to have a little disclaimer just because it's sort of some medical advice or whatever. So opinions, comments and statements during this session do not constitute as individual clinical specialist opinion or advice. So for a specific medical concern, of course, individual assessment, GP, medical and physiotherapy specialist advice is the best way to a good treatment plan. Sorry, I had to get that perfect. So yeah, we will carry on, and Pat is having a day off down in Cork, so he looks like he's a nice background in the sea behind him. And Niamh is at home, so will we start with the first question, guys? So the first question came in from Claire, and this would be a question for Pat and Niamh. So here we go. Claire has scoliosis. Claire had scoliosis surgery, a fusion, completed in 2009, and she still gets pain on and off. Plus her ribs are still sore. Is this common to still have the pain, or will it eventually go? She's 26 and she exercises daily. So what do you think? I'll ask Pat first.
Okay, good morning, and thanks for the opportunity to do this. If you look at scoliosis, it was often said that it's not a painful condition, but it's actually about 70% of patients do have some pain or discomfort. And even with surgery, it's true that people do get back and spinal pain and sometimes rib cage pain. About 10% of people who have surgery still would have some symptoms after surgery, requiring occasional painkillers. It's very good that she's exercising regularly. We would certainly see that even in the general population, up to 40–50% of kids will occasionally get back pains, regardless of the scoliosis, and about 70% of adults. So that's got to be borne in mind. In general terms, what's really important is after surgery, you're going to be weaker. And even years later, you can get weaker as well, just in your general torso and body strength. So exercising and specifically doing things which keep core strength and flexibility and adaptability as you get older is really, really important. And is often a huge part of the solution. Having some sensitivity around your ribs, because the scoliosis has been corrected, it certainly is possible to get sensitivity around the costotransverse joints, sometimes in the ribs, sometimes the little nerves which are traveling around your torso can be a little bit sensitive. So there can be specific things which can help that. And certainly from the point of view of non-pharmacological or non-medical ways of improving things, we see sometimes that even simple things like vitamins, like vitamin D, vitamin C, magnesium, calcium can actually help take the edge off. But I think a lot of patients, when we look at it, can really benefit from physical exercise and conditioning, and a specific analysis of where their pain is. A very common area they get discomfort is between their shoulder blades, around their shoulders and around the ribs. And very often it's because they're a bit weaker after the surgery, or they're just got weaker as the years go on. So doing specific targeted program can really help that. Finally, of course, anyone who's getting increasing pain and major discomfort, that needs to be analyzed. It's very, very rare to get late infection or or to have a real mechanical problem with the spine after surgery many years later. But if there's a really severe issue increasing, then of course that's where you need professional review.
Yeah. And Niamh, thanks, Pat. Niamh, you're in the Scoliosis Academy, so you'd see this probably quite a lot.
Dee, thanks for having me this morning as well.
You're welcome.
Yeah, basically just kind of leading on from what Pat said, I would probably start with a proper assessment just to make sure there was nothing else going on. If she's already doing exercise, you know, she's already got a good head start on most people. It would probably be a case of identifying the areas that she needs specifically to target. And usually what I'd find is that there's a lack of endurance in specific muscles, so probably targeted rehab as opposed to general exercise would be where I'd start.
Yeah, okay. I hope that helps, Claire. Yeah, so the second question we got in was, Megan is on her second brace now. She's 6 years of age. Is she too young? She's got a, I can't pronounce this, a Rigo brace, yes. She's 6 years of age. Is she too young to do physio?
So
her mum wants to know.
With the Rigo Chanel brace, we tend to target it with the Schroff method. The two work in combination with each other. The benefit of the Rigo brace is that you're having forces generated in certain areas to encourage the body to move in what we call a proprioceptive way, so that's body awareness. And the Schroff method works on the same basis. It's trying to re-educate your nervous system to how to move. For a 6-year-old, that specific exercise can be quite difficult. So if she wanted to start off, it can be nice at that age to start getting into the routine of basic exercises done daily, but also at that age, I'd probably could start with fun game, obstacle courses, just something to get movement going in the right kind of ways. And if she already likes exercise and sport and is already doing lots of it at that age, it's probably good enough. And then as she gets a little bit older, probably from 7 or 8, she could start the more targeted stuff if they wanted to.
Just a question on that one, Niamh. From my sort of rough understanding and experience, getting the kids early into sports and programs that they enjoy, like martial arts or dancing or swimming, kind of, for me, I see that the kids who do that kind of stuff are much better. What do you think?
Yeah, hands down. So any of the kids who are working with me know that the one rule that I have is you have to do 5 hours of exercise a week, but that can be whatever exercise you want it to be. So the younger you start getting children exercising, the more normal that is, and it's more part of their routine and part of their life, and they love it. So get them doing stuff that they like. We are big advocates for the martial arts and swimming and dance, but all sport is good, and the more movement you can be doing, the better.
Yeah, that all sounds great. And then we've, like adding on, we've got the Straight to Swim that is brilliant as well, so she could definitely go to that too.
Yes, that's a great idea.
Yeah. Perfect, thank you. So we're on number 3. This came in from a little boy and he wants to know, I made sure when I put the post up that parents ask their children what questions they wanted to ask because it's about them. So this little boy wants to know, if you have rods, and I have rods, I'd actually like to know this too. Can you get hit by lightning if you've got rods?
It's a very good question.
Really? Okay.
Considering there are thunderstorms hitting the northwest of the country today, anyone can get hit by lightning if they go out in a thunderstorm. So, in theory, anyone can get hit by lightning, whether you have rods or not.
Okay.
So I would just stay out of lightning, regardless of whether you've had scoliosis surgery or not. I think that's the best policy. I wouldn't go testing it.
Don't go testing it. Okay. You should put a disclaimer on the rods then. That would make sense.
No, because any human being out in a lightning storm could get themselves into trouble. So
yeah.
I think.
Okay. That was a question I had too. So that's good to know. Yeah. Another question that comes up time and time again is, if you have rods, do any specific rods go off in the airport, or do the newer rods not go off in the airport, or what is the story?
So the story, as I've heard it, from lots of patients who've gone on holidays and traveled after surgery is that they don't go off. And we use quite commonly things like steel or cobalt chrome, which are fairly heavy or dense metals. And it's very hard to understand why they don't go off, because if you have it in your hip or your knee, it will go off in the airport, but spinal rods don't set off airport security alarms. But if anyone's concerned about it, what they can easily do is have a screenshot of their rods from their x-ray or whatever, and they can have it in their passport or on their phone if there's any question. But the general finding is that across the world, spinal rods do not go off.
Okay.
Don't set off alarms.
That's good to know, because everybody's nervous going through.
Everybody is.
Anyway, so then when you have rods, you just think, oh God, they're going to stop me and I'm not going to be able to prove it. But yeah, that's good. Take a picture of your x-ray. Thank you. So what are we on, number? Yeah, this is a question for Pat. Maybe Niamh as well. I'd like to know this too, because I know you quite well now, Niamh. What do you both do on your day off? Pat, do you ever have days off, or?
I have a day off now today. So I'm listening to the wind outside, and so if all is good, I'll be taking the dogs for a run, something like that later. But also I'll be looking at getting a chance to go windsurfing or surfing. Okay. So water sports is something that, yeah, I do if I can.
To relax.
Yeah. And that's a future plan. Hopefully we're going to start a scoliosis SUP program.
Surf program.
Stand-up paddle boarding. I reckon it'd be a great exercise for kids with scoliosis and for adults with scoliosis too. Because Ireland's surrounded by water. There's lakes, rivers, and ocean everywhere. So anyway, we'll keep you posted on that possibility.
I'll have to learn to swim first, as usual. Okay.
We'll give you a life jacket, Dee.
Yeah, thanks. Niamh, what do you do on your day off?
I suppose I'd be quite like Pat as well. I'd be active, so either running in the mountains or swimming in the sea, or if and when this COVID epidemic ends, I'll be back playing football. We're looking forward to getting back onto the pitch.
Oh, good. Okay. So you both love extreme, dangerous type sport to relax. Okay.
Depends what you define as extreme. It's not that extreme in some ways.
Surfing is a bit scary. So next question, Pat, why did you want to fix bones? Why did you start doing orthopedics, basically?
That's yeah. Actually, now that you ask me, I haven't put a lot of thought. I guess one of the things that I was understanding as I was going through med school and the early years after med school was that I wanted to do something physically with my hands. I was much better at technically building or doing something, and I liked surgery for that reason, that you have a task, not just the consultation and meeting patients, but also a physical task to do something. And I was lucky enough to get proper training down in Cork, you know, and I did the accent goes, yeah. General surgery and plastic surgery and vascular surgery and cardiothoracic surgery. So different parts of and even a bit of neurosurgery. And in that time, I also got experience in the orthopedic department. And I suppose what attracted me to orthopedics was the nuts and bolts of, especially with the fracture care, if there's something wrong, you can fix it. And it's very defined. And so we set yourself with a target, a problem that needs to be solved. You do a mechanical procedure and it changes the patient's life. And I guess down through years of orthopedics and then into kind of spine, which is both orthopedics and neurosurgery work in the spinal area, but we do special spine training. Scoliosis surgery is probably one end of that reconstructive part of surgery. And bones are fun. Everyone needs their bones to be solid and strong and in the right shape, and whether it's in your arms or your legs or your spine, sometimes if that's going wrong, then it makes a big difference if we can help. And I tell everyone I'm one of the luckiest people in the world to have the job I have, because almost every day you see a case of somebody who was a big challenge, and 6 months, a year later, they're a different person. And that's, for me, the most positive thing in my life. One of the most positive things in my life. Yeah. That's so great. I'm very lucky with my job. yeah. And that's why I do bones.
That's why you do phones. That's amazing. It is kind of like what they say. It's kind of like a carpenter, I suppose, that you do fix things or make things better, or
Yeah, I suppose there's a physical element to restoring, but I suppose we haven't got it perfect, which is also one of the interesting things. We don't always have the exact formula for lots of the challenges, no matter what technique or technology we have. Nothing is quite perfect. We'd love to be able to make everyone's spine flexible and adaptable, but Niamh is far better at that than I am. In fact, she's most of the time rebuilding people from the stiffness and tightness and weakness that they've got after their surgery. So I think we all have different skill sets. So I think it's not all or one. And people who have an understanding of the different things that they can provide, that leads to the best outcome for the kids and adults that we look after.
okay. And Niamh, I'd like, what would be your answer to that?
For why I got involved in physiotherapy and
Yeah.
I suppose the reason that there's loads of reasons, it's hard to pick just one. I always wanted to work with people, and I always had a massive interest in sport, which is what led me towards physiotherapy. And then I just found the nervous system extremely interesting, so neurophysio and spinal physio both kind of intrigued me. And then just with the way life happened, I got more and more involved with spines. And then I actually moved to Canada and became interested in hypermobility and was intrigued by that, and then saw the link between hypermobility and scoliosis. And then once we started working on scoliosis, I just couldn't believe the results that we were able to get through exercise and bracing, and then even just the amazing surgeries that can be done to really change people's lives. So since I started working on scoliosis, there was no turning back.
That's amazing.
I actually wanted to be sports medicine specialist. Initially, that's what I thought I was going to do, like the trauma and the sports. But along the way, one or two of my bosses said, you should think about doing spine and pediatrics. And I was like, who, me? And they were like, yeah, you should. And I was like, oh. So then I started looking at it more realistically, thinking maybe it's not that crazy and extreme a sport. Maybe it is a part, something that I could do. So ultimately, that's how I ended up there. There's people saying to you, actually, you've got possibilities to be able to do this. I think why we call it Scoliosis Academy is for me.
Yeah.
And hopefully for all of us, it's a continual learning.
Yeah, agreed.
Even though it's scary to say it, but more than 10 years in Ireland as a scoliosis surgeon knows, there's still every day, every week, you're learning things. That's why we kind of came up with the name of the academy.
Okay. And I think just on a personal level, as you say, with myself, I had the big correction, and like, while it is fantastic, I do find that I'm quite stiff and sore. So I do feel you have to go further to do physio.
You have to keep working. You have to keep working on it. But that's true for most of us. Even without scoliosis in life, we need to keep working to be the best versions of ourselves we can be. And so, as all my patients know, I say, be fit, be flexible, be strong. That's your job. And we tell them that regardless of whether they're having an operation, and especially if they are having an operation, it's a lifestyle afterwards is really important.
Yeah, definitely. I totally agree. Yeah, that's great. So will I go on to the next question? Yeah, where am I now? So this kind of comes up a good lot as well. So one of the mothers wants to know, do you think VBT ASC would ever be offered in Ireland? This lady's daughter went to Germany and it was a success.
Okay, so VBT stands for virtual body tethering. Okay, so this is about fusionless correction, partial correction of scoliosis and managing scoliosis without fixing the spine. And do I think it would be offered in Ireland? I do think so. I think it'll be offered around the world, but you'd have to understand that the answers on VBT are not out there fully. So some patients can do very well, some don't do as well as hoped for. And there's no doubt that the complication rates are significantly higher. for VBT. The other thing is there is a gold standard, which is corrective surgery, and it's hard to consider going through a different kind of treatment with a patient when they're going to have a 10 to 15% chance of a significant complication. The other thing with vertebral body tethering is we don't know the long-term outcomes. We don't know 5 or 10 years down the track how are they going to do, or what will the problems be then. Whereas we do know, have a much bigger understanding of the natural history for people after modern day corrective scoliosis surgery. The last thing to say about vertebral body tethering is there is inherently, I suppose, an attraction to keeping movement in the spine. That's what we'd love to do. But it's most important in the lumbar area. So I think in the long term, what we'll see is that we will have a hybrid of treatments where some patients will have tethering in the lumbar spine to try and preserve lumbar movement in the low back. And then maybe the thoracic spine, we mightn't consider tethering, we may do a correction. So it's a big debated area in the children's spine world. But I think that there's not a huge amount of literature actually published on this, which is a big question for me, because if there's 2,000, 3,000, 4,000 patients who've had this kind of treatment, why is there only small groups reported on? And we know from the national registries that the rate of complications for the VBT groups is extremely high and often not published. There's really good literature from Peter Newton in San Diego looking at this objectively, which shows actually that the complication rates are very high, much higher than conventional surgery. So that's why, even though I love the technique and it's in terms of being able to do it, we can do it, it's making the choice for that child who is our responsibility to put them potentially at risk of complications, which it's a difficult dilemma. But certainly we're happy to discuss it and consider it with any family, any patient. It's just, I haven't found the perfect patient yet for it.
Okay.
Yeah.
Okay, thank you. Neve, have you seen patients that had that done, or?
Yeah, so a couple of kids who come from different places, a lot of them from Turkey, surgery in Turkey, have come to me for treatment after. One of the things I would notice with it is the imbalances would still be there, talking about the rib pump and things like that. So that's when the repeats with the scoliosis, it doesn't correct as well as the gold standard spinal fusion. And the kids also have to continue to do quite a lot of rehab following the surgery. So not just general strength and conditioning to get going again, but I mean the spinal exercises again. So it's something to take into consideration, because even post-surgery, there's still a lot of work that I would say needs to be done.
There was a really good presentation from one of the centres that does vertebral body tethering at the last BSS meeting in Cardiff. And so that's a very reputable centre. And what they showed was in the thoracic spine, which is where most kids have their scoliosis, there is no benefit in terms of range of movement, and the amount of correction is less. And if you add that to the higher rate of complications, and my fear is when something goes wrong in the front of the spine with instrumentation, it's much more dangerous. So if you add those factors together, you can see why we're a little bit cautious about charging in with a new technology and a new technique, even though it looks very attractive on paper. That's, I suppose, where most of us would consider it. But I certainly have an open mind on it.
Yeah.
But primarily, I would say for the thoracolumbar and lumbar spine. So slightly lower down in the back where the movement is a crucial thing. But you will have to say, as Niamh is saying, that you get less correction with VBT as well.
Yeah.
But you potentially can preserve motion. And crucially, of course, if we can do anything to preserve motion in the lumbar spine, we should do so. That's one of the reasons we're very much pro early assessment and, if necessary, management to try and preserve as much lumbar movement as possible. And if we do need to do surgery, to consider fixing earlier and when the lumbar curve hasn't got too bad.
Yeah. Okay. Thank you. Yeah, so will I move on to the next one? Yeah. Yeah, so this is for both of you. A few of the same people sent in the same questions. why did you set up the Scoliosis Academy, and where is it, and how do people get there, or how do they apply to go, or what happens?
I think I answered this already. I suppose
Yeah.
one of the things we've been looking at for a while is the need to try and bring things together in scoliosis care. For me, always thought we did need a central situation where people would focus on providing the best solutions possible, and that we could link together in a collaborative way, which I guess we were doing in an unstructured manner. So Niamh and I have been working together for about 2 years, is it, Niamh, at this stage?
2 years now.
Yeah, and I remember I was having to teach quite a bit about scoliosis and lecture and whatever, and I was revisiting the bracing and physiotherapy evidence, and I was like going, well, you know, my concepts on bracing and physiotherapy were old-fashioned and out of date, and the Schroth strategy and the modern day bracing has certainly transformed management in my eyes in the last 18 months. And I came to that realization as I was having to prepare a lecture, and I was like going, okay, how are we going to get people to proper Schroth and to proper bracing? So thankfully we've got the Rigo Shano brace for the last year now, or 14 months I should say. So that was a process of 3 years trying to get modern 3D computer aided design molded braces. So they're a big step forward, I think, and obviously the physiotherapy has been a big step forward. So we know that with good physiotherapy and bracing, we can change where people are going for at least 50% of them. Okay, why Scoliosis Academy? I guess we wanted to be able to pull together assessment, treatment, whether it's physiotherapy or bracing or both, information, communication, teaching, research, all relating to scoliosis into one place. And that's what Scoliosis Academy is. And we use the term academy because, as I said before, for me, I'm on a lifelong learning expedition, if you like, and I'm only at the start of it.
Yeah. What's your answer, Niamh?
Similar to Pat, I suppose, as well. I think a big part of it as well has been the two of us have been listening to patients and families this whole time as well. And it's horrible to have to watch somebody travel halfway across the country, then have to go halfway across Dublin for different appointments and back. It's like a yo-yo. So I think we're trying to take the stress out of it as much as we can, to have the specialist care in the one place. So if you wanted any management of your scoliosis or spinal issue, you come to Scoliosis Academy and we'll look after you there. Like, that's kind of it. And then on top of that, we want to continue to learn. It's a big part of why we're in the spine world. We want to continue to learn. We know that we'll learn from each other. We'll know that we can educate others, be it patients, families, colleagues, and we want to be able to do that from the one place. So we are in the Beacon Hospital in Suite 30, and if anybody does want to reach us, the best way to do it is through our email address, which is info@scoliosisacademy.ie. That's probably the best way to get us.
Yeah, or if they want to straight ahead, I can send it on. Yeah. So it's like a center of excellence, basically. Really.
It's a center of focus and learning and hopefully excellence. The other thing is we'd like to continue to develop our collaboration with different people and individuals who are in scoliosis care around the country, so that people won't necessarily have to come to Dublin all the time, but that maybe we'll have people who are with Scoliosis Academy also in the West and in the South, and we're building those links. Some of them exist already, but making them stronger is a great thing, I think. So that's how we look to go forward.
That's the dream. Yes. Thank you. So next question. So this is for both of you again. So Anna's son had spinal surgery in 2018. He was complaining of pain a lot post-op. Pain management sorted this out for him, but now he's complaining of some shoulder pain. What can he do? What can he do? He has other needs as well, so his mum's a bit lost in terms of what to do.
Okay, great question. I would say about 10 years ago, I remember I was chilling out. I was at a conference, but I was just, after the session, I was just thinking about things. And it struck me that if with scoliosis, you've got a large twist in the spine and in the rib cage, that the shoulders have to be off balance. And therefore your shoulder and muscle function and your shoulder blade function has to be somewhat asymmetric. And from that, we started looking at how much had been researched in the area, and actually very little. So working with Trinity Physiotherapy, with Alison Quinn, who was there as a lead at the time, they did a postdoc work on analyzing shoulder function, and they identified actually that if people after surgery, and even just people with scoliosis, have definite asymmetries and weaknesses in their shoulder girdle. So the muscles that connect your scapula or shoulder blade to the rib cage, that they're not working very well. And definitely I would say surgery would disturb that. So the team in Trinity worked on that further and started to develop a program of exercises and conditioning things for those weaknesses. And it's often really helped the shoulder problem. So if it's just, it can be, as what I'm saying, I guess, in a long roundabout way, as I usually do, is that you can have a shoulder imbalance or muscle weakness, which can lead to pain because of tiredness, just the muscles get sore. Of course, if there's a lot of very severe unremitting pain, then it needs a proper medical analysis. But a lot of the time it is that you're a little weak in one area or another, and targeting that zone to make it a bit stronger, more adaptable is what's required. I know I probably alluded to this earlier. Over to you, Niamh.
Yeah, exactly. With the scoliosis, it's not just the spine that's involved, it's your whole thorax. So part of the rib cage is coming too far back and part of it's coming too far forward. So that means your shoulder blades, one pushes too far back and one sinks in. And the reason that's so important and so relevant for your shoulder is that your shoulder blades guide your shoulder movement. So if your shoulder blades are sitting a little bit funny, it means that your shoulders are also going to sit a little bit off. And you'll see that in scoliosis, how one shoulder will sit higher than the other. So if you have that pre-op and then all of a sudden somebody comes in and completely changes it, your body doesn't know exactly how to move. It hasn't been taught the new movement, and all of a sudden there's a new structure now in the way. So where there had been a gap and where there had been a barrier, that's now gone, and the shoulder blades now sit or should sit more flush. But your shoulders, they haven't got that memo. So a guided rehab usually can help to change that. I did note, I'm not sure who the sender was, but they did say that the child had other needs as well. So depending on what those other needs are, they might need a bit more assistance, or their rehab program might need to be a little bit more structured to adapt to that. But you know, any level, there's always exercises that can be done, and if they've gone through the surgery and haven't had any specific rehab, that's probably a good starting point to try to help decrease the pain. So if you're stronger, pain tends to go, because usually where there's weakness, then that's where pain starts to come from. So if you can kill the weakness by creating strength, the pain tends to go away.
Yeah, that's okay. And can I just add, so if you're, say, a wheelchair user, or you're not as mobile as somebody else, like it's fine to still do exercise and everything?
Absolutely.
Yeah.
Okay.
Even more of a reason, you know,
yeah,
if you're not getting up and getting the usual blood flowing through the body, you've got to be creative and find other ways to do that. And that's the joy of physio, is being creative and coming up with different programs to match individuals' ability. So if somebody was stay in a wheelchair, there's, especially because it's a show, there's so much that you can do for them. And if I'm not sure if this individual is in a wheelchair or not, but if they were, and they now have their new shoulder position and they're having to use a wheelchair, of course that's going to cause a shoulder problem. You're going to have to do some work on the muscles in the back of the shoulders to equal out the imbalance.
Okay.
Yes, and adjusting or adapting their seating, but that's normally thought of after your scoliosis surgery. Normally people factor that in, but yeah.
Yeah, okay. Thank you. Another question. Sorry, where am I? Yeah, so Rachel got her, number 10. Oh yeah. So Rachel got her surgery in Crumlin in 2014, age 12. Her curve was reduced from 86 down to 41 degrees. She had absolutely no complications. She keeps getting weird jutting leg movements and sometimes whole body jerks, and then it's suddenly gone again. It might happen once a week, or it could happen every day. She also has some numbness in her left arm. She had no pain before the surgery, and now she's pain most days. What would your opinion be on this?
So I think anybody who has pain, if it's a significant issue, it needs to be evaluated carefully by people who are, of course, involved in the care. Occasionally, you may have a situation where something can change. While the rods and implants are designed to go in for permanently to hold the position, the body is designed to move, and sometimes bones can, the skeleton can move a little bit vis-a-vis the implants. Occasionally, you might have a failure of the spine to fuse 100%. So if you like, 95% of it might have fused, but there could be little micro movement somewhere that can lead to discomfort. I certainly would think that anyone who has, okay, it's not unusual to have a little bit of numbness in one band under a rib or one little zone like under your arm or something like that. That's not normally a major source of alarm, because the little nerve branches which are coming through the spinal muscles have to be moved out of the way for the surgery. So, but I guess if you have progressively changing phenomenon, that needs to be looked at. Finally, lots of us get little jerks like when our arms or legs fall asleep or awake, and that can happen to you sometimes out of the blue. And it may be nothing more than that, but I certainly would say the situation needs an evaluation. And sometimes we think about a scan to look at three-dimensionally where everything is at. And that can be very helpful, particularly if you're going to go towards physical therapy and exercise afterwards, just to be sure everything is secure. That's reasonable.
Yeah. Okay. I do know myself from having scoliosis that when you do sit in the one position for too long, sometimes my leg goes dead, so I have to sort of move.
But that happens to everybody, potentially.
Okay, I'm normal then. Okay.
Yeah.
Yeah, Niamh, do you want to answer that, or?
See, it would need to have assessment for something like that.
Yeah.
Scans done just to clear out any potential.
Yeah.
Now, in saying that, sometimes we do see cases like that, and everything's perfect in their spine. There's no issues at all in the metal work, and it's just a case of getting strength, getting stronger.
Yeah.
And I have seen that phenomenon before, where somebody's a little bit jerky or twitchy, and they, more so than the norm, they get stronger, and that goes away. So if everything was clear, exercise is always an option to try.
Yeah. Okay. Yeah. So number 11. So this is for Pat. What is your opinion on magic rods? So this lady, she has read a lot of bad press about them in the media this year. So she'd rather know a professional opinion than looking at anything in the media. She's heard some fantastic positive stories as well. So she just wants to know a surgeon's opinion, basically, on magic rods.
So I guess it's a really interesting question, and one that we reflect on quite a bit. So the issues that were kind of, I suppose, highlighted in the Irish media about magic rods really were not highlighted around the world as much. For whatever reason, it became an issue in Ireland. I guess one of the concerns we have is in the children who have a specific condition called early onset scoliosis. So in early onset scoliosis, it's kids who are under 10 years of age. We know that up into your teens, your spine has to do a whole lot of growing. In fact, by the age of 5, your spine growth is up to 2/3 of its final adult length. And in the first 8 years, the critical thing as your spine is growing is also that your thorax and lungs are growing. So we know that if we have spine deformity at a young age, we want the spine to grow straighter ideally and allow the lungs to grow in terms of size and volume. If we fix the spine in a major way, we stop that growth. So we need growing rods which allow us to control the spine deformity if we can't control it with any other means. So normally we'll use physiotherapy, a cast, a brace, exercise, everything we can do if it is a progressive scoliosis to hold it back and slow it down or correct it. But sometimes those treatments are not enough, and then we need to consider what the options are. And a growing rod is a rod which normally has fixation at the top and bottom, and the middle of the rod we can elongate. So we can control deformity to some degree, and then allow or encourage the spine to elongate with a growing system. and that's for a very specific small group of patients with early onset scoliosis. The traditional growth rods had a drawback, and that was the fact that to be lengthened, they needed to be physically lengthened by an operation. So each child was therefore coming in, if you could get an operating list, for a lengthening procedure on average every 6 months, which meant that during someone's childhood, you had multiple operations. And I remember one kid who had the final surgery, because growing rods are an interim treatment which you'll use for your young years, and then when you get to teenage years, you do a final definitive operation like a teenager would have. Remember the kid, he said to me, you know how many operations I've had? I said, no. He said, I've had 19 operations. So there's an impact on a child, we know that, from having repeated operations. There's a risk, there's an impact potentially from having anesthetics repeatedly. Not everybody, but some kids. And I suppose every operation is some degree of trauma. So magnetic rods are designed to be elongated in the clinic, that the magnet will allow the rod to elongate. And we still think it's a valid treatment to be considered, but at the moment the magnetic rods are being evaluated completely. And they're not completely unavailable, but they are, and they're sometimes the right choice for some patients. So in general, for kids who shouldn't be having multiple general anesthetics because of medical reasons, or kids who are younger or lighter, then we'll consider magnetic rods as still maybe the optimal treatment choice. But if it's someone who's bigger, older, with a higher body mass index, or otherwise complex or rigid in terms of deformity, we know the magnet won't be powerful enough to work, and we probably won't use a magnetic rod in those circumstances. Finally, I suppose part of the media focus was on the implants and whether they were working or not. And specifically, there was failures reported. We've looked carefully at the patients in Ireland, and we haven't seen any major issue with regard to mechanism or implant failures in the over 80 kids that have had this treatment. So far, most of the kids have been doing reasonably well in that program without multiple operations. And that's really been a godsend, especially in the COVID crisis.
Yeah.
So it's still a valid treatment choice in general, but of course the specific needs of your child and the specific issues in your child's care need to be teased out with your surgeon.
Yeah.
And
but they're not for everybody, but they're
not for everybody, but they never were. And growing rod surgery is not for everybody. Indeed, looking after early onset scoliosis is not for every surgeon either. It's quite a niche area, and it maybe for me it's a significant part of what I do, but that's not true for spine surgeons across this country.
Yeah, that's good that you cleared that up, because obviously when you read something in the media, I'm not a parent, but you know, it would be scary if you do read something negative, but I think it's better to ask somebody who knows.
I guess one of the things about the media in general is that it tends to focus on negatives and sensationalize rather than being objective and factual. And one of the difficulties from my perspective is none of the positive stories are being portrayed. None of the outcomes that are positive. So there's no balance in the way that story was presented. It was all boom, boom, boom. And in fact, the fact that no child in Ireland really had an issue was not at all highlighted. In fact, we had lots of people who were terrified they'd had magic rods, but we actually had no evidence in Ireland that we had any problem. We just knew there was a small amount of cases around the world. We were fully aware of it, but we watch all kids with every type of growing rod very carefully, because we do see complications go with early onset scoliosis. That's part of the territory. It's just part of the challenge of trying to manage very young children with spine deformity. It's a big challenge, and that's because growth is not their friend, and their biology, with all the time posing challenges, the way they're growing, the way they're going, is going to be kind of counteracting whatever we're trying to do to help. And so we know we need to watch this closely. That's what we do. Yeah.
That's great. Thank you for clearing that up. Yeah. Good question. Yeah. Will I move on to the next one?
Sure.
Yeah, so another one. So my son has congenital scoliosis. He has pectus carinatus,
Carinatum.
Carinatum. Do you do the NUS procedure? NUS procedure, or is there a different way of bringing the chest wall out?
Okay, so there's two elements here that are sort of connected to some degree. Your spine is connected to your rib cage, and your rib cage is connected to your sternum or breastbone. Occasionally, scoliosis can have an impact on how your chest and thorax is developing. But it's also true that sometimes your chest can have asymmetry or abnormal development of its own right. In congenital scoliosis, we often see disturbances of formation or separation of the vertebrae. In those patients whose vertebrae are like that, often the other elements, so their ribs or their sternum, may also have different but associated anomalies. So they should be looked after separately.
Okay.
While correcting the scoliosis or spine deformity might lead to an improvement in the rib and sternal and thorax shape, in a pure sense, the chest wall shape may be something of its own independent entity. It may, its own make. So we would say that the NUS procedure is something that would be considered for someone with pectus. Okay. Now, I don't do it in some countries. Orthopedic surgeries do anterior chest wall surgery, but in Ireland, it tends to be done by specialist thoracic or other allied.
Yeah.
Call coming in. So we would say, look, there's a pectus clinic, and if you need an opinion, that's where I would get it, and I would leave the decisions on whether you brace the pectus or whether you do an internal procedure to the people who are specialists in that area.
Okay. So that would be a thoracic surgeon.
So, well, yes, but there's not very many of them look after this. So I would say it's reasonable. There is a pectus clinic, and there are thoracic surgeons who I rely on if I want an opinion.
Okay, that's grand. Okay, will I move on to the next one?
Sure. Yeah.
So another lady said her son is 13 and was offered costeoplasty surgery. She has heard that this is an old-fashioned surgery and isn't done very much nowadays. She also heard it's extremely painful. Is there a more modern way of doing this? Is there a more modern way, another way of doing this to help the child's rib pump?
Okay. So costoplasty is a cosmetic procedure, or labeled loosely as a cosmetic procedure, to realign the ribs and take away the prominence. It's very rare that I almost never see it now or never do it now, because when we do scoliosis correction, normally we can derotate the spine, so then the ribs which are attached to the spine will then come back around. So the rib prominence is often less than 50% of what it was before surgery. I don't know if this young man has had scoliosis surgery. So in the old days, when they didn't do much correction, we'd often see significant rib cage asymmetry. And it's true, if you look carefully at any scoliosis patient, you will see subtle or moderate rib cage asymmetry, because as the spine has grown abnormally, so has the rib cage. But the vast majority of patients now after correction don't require costoplasty. It can be considered. It certainly, for me, I would always consider getting a CT scan to get a three-dimensional map of what the rib cage looks like and what you can do. It does mean, if you like, cutting the ribs and realigning them in a different position, often shortening them a little bit on the long side, which is the convex side. It can be a bit sore afterwards, and you might need a chest drain, and it will take a bit of time to recover from it. So it's not a nothing procedure. It's a rare enough for me to do it. I've certainly had a few patients where we've done it, where we've considered it, often in a revision scenario. But that's, I suppose, what it is. But again, it's about getting the opinion from a specialist if you are going to proceed with it, and how much your child really wants it. It's also reasonable in a 13-year-old to say, look, if it's not bothering him now, he can make his own decision on this when he's 16 to 18. and that's because it's not going to change hugely, and often we will wait for growth to stop before so costoplasty would often have been postponed into later years. But it's very, very rarely a discussion in my world now.
Yeah. Okay. Okay, I'll move on to the next one. Sorry. How many X-rays are too many? Mother wants to know. Her daughter has scoliosis, and she seems to have gotten a lot of X-rays.
That's a great question, and that's why we fought tooth and nail to raise the funds to get an EOS scanner in this country. One of the concerns about repeated X-rays, particularly in females, is the radiation dosage accumulative over years can have an impact, a negative impact in terms of your risk of changes because of radiation in your later life. I suppose how many X-rays is too many? Well, any X-ray is a dose of radiation, so one is too many if it's not needed. And we therefore always have to be careful about exposure. So if we can, we try and get an EOS scan for everybody. People shouldn't really have X-rays if it can be avoided more than twice a year. We often don't do lateral X-rays or side shots unless they're really, really required, because there's a higher dose and you're obviously getting 2 X-rays when you're getting one from the front and one from the side. So you don't need to have 2 X-rays every time. And yeah, sometimes we're looking at systems, and hopefully in the future we'll have them where maybe we can use an ultrasound to map the spine, which can give us a good indication of what the X-ray might look like. So that'll be useful for screening, but I don't think it's useful for really monitoring true significant scoliosis. So there are concerns about X-rays, and the less is better, and the lower radiation dose is better.
Okay. And just when you spoke there about EOS, do you want to explain a little bit more about what EOS is, or?
So EOS scanner exists in Crumlin. It was an initiative that Straight Ahead and the Children's Medical Research Foundation had together, and it's one we're very proud of. It looks like a shower.
It does look like a shower.
And if you think about a conventional X-ray, and a conventional X-ray is that you stand in front of a plate, it's like a screen, and you get a shotgun blast of radiation, which throws a photograph of or a negative image of your bones on the screen behind, and that gets picked up on the film. So that's how an X-ray is generated. With the EOS scanner, you have a very, very fine beam of targeted radiation going linearly and then being picked up by a very, very sensitive scanner behind. And this moves down along the body in one beam. So there's not massive scatter, and there's a much lower dose. And and it also allows you to rebuild a 3-dimensional image. So in one picture series, you can get a lot of information, better quality and much lower radiation than conventional X-ray, and much lower doses than CT scan if you want to do 3-dimensional analysis. So that's what an EOS scan is.
Wow.
And it's also much quicker and cheaper.
Quicker and cheaper, yeah. Which is obviously the good thing. Do you need to wear the heavy kind of apron things with an EOS scanner?
So the EOS scanner is for the only person in the scanner is really the child. So we're not in the room getting the dosage or exposure, but the exposure for the child or adult in the EOS scanner is much lower.
Yeah. I just know from all the X-rays as a child, or maybe it's just a female thing, you have to wear the big heavy apron thing.
So we'll try to protect areas which are sensitive. So often kids will have shields over their genitals or whatever.
Yeah, but is that with EOS as well?
So if they need to shield an area, they will.
Okay. Yeah. It's quite heavy, that thing.
Okay.
Yeah, so next one. Yeah, so this is for you, Pat. If you were not a doctor, maybe you kind of touched on this already. If you were not a doctor, what would you like to be?
I don't know, actually. I guess I'm a surgeon. I'm not a doctor. I'm not a proper doctor. Yeah. I'm an orthopedic surgeon, so I'm even more. I don't know. like a carpenter. So maybe
A carpenter?
maybe I'd be a carpenter or a boat builder. That's what I think I'd probably be, or build surfboards or something like that. Yeah,
You could do that in your spare time.
yeah, I could. Yeah, yeah.
Um,
Spare time.
loads of spare time. We can never get you. You're so busy. So next next question. This is one that comes up time and time and time again, and I think it's a very important question for kids. Is it okay to go on a bouncy castle with scoliosis?
Niamh?
Yeah.
Yes.
I would give the same advice to anyone asking this question. As long as you're enjoying yourself and not doing anything too crazy, you're fine on the bouncy castle. A scoliosis is a twist in the spine. The spine is as strong as anybody else's, so it's not the scoliosis that should dictate whether you go on or not. It's the actions that you take when you're on the bouncy castle. So yeah, have fun, don't do anything too crazy, and you'll be fine.
Yeah.
Yeah, same with trampolines, same with anything.
Yeah.
The other question that comes up is after surgery. And we would generally say, look, we don't want to restrict people's activity and recovery and rehabilitation, and we don't want them to be afraid. So, you know, it's reasonable to go gently and steady in a sensible manner for 3 to 6 months after surgery.
Yeah, of course. Yeah.
If it was somebody post-op, if they're working with me and they're a post-op patient, they'll have certain goals that they'll have to reach before they're allowed to go on the bouncy castle or the trampoline or to do certain activities. So their rehab would be guided to allow them to do that with confidence. But in terms of their actual time, they're good to go.
Yeah, okay. Can adults go on a bouncy castle?
Not with kids.
Probably a good idea.
We see the biggest issues with bouncy castles and trampolines are when you have big children or adults with small kids who are way more fragile. It's just Einstein's law, you know, mass. You know, so heavy people, like in collision with lighter people, the lighter individual comes off worse. Okay.
Yeah. So next question. So this would be for Niamh. What's the best exercise you can do before you get your surgery?
That's a great question. That's tough because there's obviously a number of different areas that would need to be worked on, and everybody is different. But the kind of gold standard thing that you'll hear Pat talk about over and over again as well would be the hamstrings. So if you are going for spinal fusion, you're going to become more reliant on the mobility of your hips for your movement and your lower back. So if you can have your hamstrings extremely flexible ahead of that surgery, that's going to give you a better chance for better mobility afterwards. But the other thing is you can't just stretch muscle, you've got to create strength in that muscle to keep muscle long. So probably a variation of an eccentric bridge, so your basic bridge where you're laying on your back, lifting and lowering the hips up and down, or you could do that with the feet raised up in the air, like up onto a chair or something. Basic hamstring stretches. And the other exercise that I love to give my pre-ops would be laying on the tummy, forehead on the floor, raising their arms up straight ahead, kind of like Superman pose.
Oh yeah.
Forehead down. That's going to work the area in between their shoulder blades. It's a nice one because when they can achieve that before the surgery and then whenever post-op they're doing the rehab and they achieve that again, it's a really nice moment because they feel like they're as strong as they were before the surgery. So things like I think that would be good. But it's a really good question. So what I'll do is I'll do up a video of exercises pre-op, my top 3 pre-op exercises, and I'll put stuff for us as well later on.
Oh, brilliant! That would be really good. Yeah. Okay. Thank you. So, what number are we on now? One was the roller coaster, but you that part.
A roller coaster after scoliosis surgery. The general recommendation for high speed. We're worried about high-speed deceleration after surgery because your spine is still healing. So the recommendation.
What does deceleration now mean, Pat?
So it means hitting the brakes, okay?
Okay.
So like, you know, that kind of feeling of whoop, where you're really, really going fast or slow all of a sudden. You don't want that to happen for a year after surgery, especially mechanical deceleration. So like a roller coaster is mechanical by definition. Okay. So getting on a horse, you know, falling off a horse, a motorbike, a roller coaster, parachute jump, we would say these are all high risk things anyway, but you shouldn't plan to do that for a year after your operation. Sport is different because sport is generated by your own speed movement, like running or twisting or turning. Often that's not anywhere near the same level of deceleration. So we are much happier to let you get back to your sport when you're ready. And often kids are back at sport within 4 to 6 months of surgery, depending on how they're doing in the individual case.
Yeah. And just to elaborate on that, another thing that comes up a lot is returning to sports after surgery. What would be the recommendation there? Obviously it's individual, I know, but
it's individual and you need to discuss it because it depends where in your spine and what your sport is and lots of things. But generally, if you're strong, fit and adaptable and you're back to where you were before, we wouldn't be holding you back from your sport. Now, the reality is that 60% of kids get back to their sport at their level within 6 months of surgery, 60%. And pretty well all of them within 12 to 18 months of surgery. There's a small percentage who weren't really in sport or were dropping out of it anyway. But it's one of our longer term goals is to look at this from a research perspective to see how did people do 5 and 10 years after surgery. And so if people want to collaborate with us on that, that'll be great. Because we're really interested to know. What we did see is that people who went back early did best. So we, Jack Noel and myself, very much pro getting people back to exercising early on, so getting exercising before surgery because that helps them to be fit and strong through the surgery, but also getting them back early. If it's swimming, if it's cycling, if it's getting on an exercise bike, and then onto gentle running, and of course physiotherapy-led exercise, even from 6-8 weeks after surgery, that's really, really important.
Yeah, and would that include dancing as well?
Absolutely.
Because you remember when the whole thing when the girl went on Britain's Got Talent and
no, I don't remember because I didn't see it, but I take your word for it.
She went on and she thought if she got her scoliosis surgery, she'd never be able to dance again. So,
well, that's I've had lots of kids coming really worried that they've been told you'll never play hurling again or you'll never be the soccer player or whatever. I mean, I've seen kids even who've had major surgery, like very extensive because of the scale of the problem, who've gone off to play volleyball afterwards or, you know, you name it, you know, professional dancers or whatever they are. So there's no reason why your scoliosis should hold you back within reason.
Yeah.
No, there's some, you know, we wouldn't advocate going into things like wrestling or rugby or things like that, you know, but ultimately, if we get there early, we can often limit the scale of what we need to do if we actually need to operate at all. Of course, hopefully, with physio, bracing, etc., we'll be able to prevent lots of people having surgery.
Yeah. Okay. I know one guy who had scoliosis surgery, and he now does the thing Conor McGregor does.
MMA.
MMA. So yeah, and he's totally fine. I'm not saying everyone can do that, but that's
I think one of the most important things about exercise and about rehabilitation and prehabilitation before surgery is finding what you like doing or adapting because what you like doing is sustainable. And we're asking people really about a lifestyle afterwards to maintain a certain level of function. So whether it's martial arts or kickboxing or boxing or hip hop or yoga or Pilates or many of Niamh's extreme routines, you know, it really is about finding what you like doing so that because that's sustainable.
Yeah. Okay. Thank you for clearing that up. So what number are we on now? Number 19. Both Pat and Niamh. If you could change one thing about your job, what would it be? I'll ask Pat first.
Ideally we'd have a children's hospital next to a surf beach on the west coast of Ireland, and then I'd be quite happy.
Go out like when the anaesthetist is putting, for surf.
I have a little dream about Dingle Hospital, and that we could find someone to buy it for us and put the scoliosis centre there, and everyone could come and we could work in Dingle.
In the middle of Dingle. It'd be a great location to recover after surgery anyway.
It would be perfect, and the families would love to come down anyway, wouldn't they? Sure, there'd be lots of entertainment,
Okay, well, Niamh?
I think we both love our jobs. We're extremely lucky in that. Probably everything that we want to change, we're working on it already, to be honest. Scoliosis Academy's been a huge part of that. That was one of the dreams, and we're on to the next stage now. I think we're both just proactive in that whatever we want the job to look like, that's what we're trying to create. So
Yeah.
maybe someday the dream and dingle will happen.
Okay. I'll certainly go down anyway for a visit. So next question, where am I? Yeah, this is an interesting question. Pat, do you think, or Niamh as well, do you think spine transplants will be a thing one day? Like if we looked at, say, 20 years ago, if somebody told you there would be a surgery that you can make a curve better in an outpatient with a gadget that moves something automatically, you wouldn't have believed that. So, like, do you think ever one day you might be able to get a totally new spine?
I suppose the question is, what are you replacing, and could we do better than what you have yourself? That's the difficulty.
Yeah.
If you're taking you're talking about transplant in its pure form. Yes, we can transplant someone's bone or discs into a new position, but you can't. Their muscles would then have to integrate and start to move it in time. So there'd be a whole process of scar tissue formation and then healing, and the chance that you could get a rejection of the tissues which are not your own. I would say that probably tissue engineering will probably replace the transplant scenario. It's a great question. I know that there are people at the moment transplanting discs, so we know that disc degeneration in wear and tear in age is something that's being looked at, but we probably think that biologically we can now tissue engineered from your own cells, which is not going to be rejected. So I would say that's more likely to be a long-term strategy, because transplants by definition need immunosuppressant drugs afterwards, and they have heaps of side effects and negative effects on your biology. So everyone would be very excited about the potential, for example, for a spinal cord transplant for spinal cord injury, but I think that bioengineering will probably be more successful than plugging someone else's spinal cord into ultimately it's a nice idea. I do think that there is going to be massive advances going forward. There are lots of possibilities, but I think tissue engineering will probably be more the way we will produce new structures. So for example, you can 3D print bone. You can make a bone-like material from scratch. And if you could then populate it with someone's cells, so it's like a new scaffold, which is actually will become part of you. But that's a long theoretical step from spinal deformity correction surgery.
Yeah. Okay.
I think a lot of people ask that question in the hope for a quick or simple fix, and I don't think that's ever really going to be the case. The other side of that is, even if you did have the perfect transplant surgery, there's still going to be a lot of work before and after that, because it's not the spine, it's everything else that's around it. So can't see a quick fix happening anytime soon.
Okay. Next question. This is interesting for both of you. Well, I suppose just for Pat. Do you use robots during spinal surgery?
Currently, I don't use a robot. Because
what is a robot? Like,
I am a robot. I am a robot.
So you do?
I am. No, one of the things is that technology is really interesting possibilities. And one of the, I suppose, lucky positions I've been in that in Ireland, we didn't have a huge amount of technology and centres providing. So we were surgery. So as things were coming on board that were used in other parts of the world, we were able to bring these technologies to Ireland and be involved at the start of it. What robots are used for is doing some operations in a very effective way, particularly in hard to access areas. So deep down in the pelvis, for prosthetic surgery, for cancer surgery, where it's difficult to get access manually, or you can do it through small incisions and small approaches. In the spine, the real role for the robot is not in terms of access, but in terms of accuracy. So to place the implants into the spine in a more accurate manner is something we've been looking at. So in the old days, implants were put in just by working out roughly where things are from the look of it on the outside. Then you've got imaging, which is to use X-ray or fluoroscopy, which gives you guidance during the operation. Next step is to do 3D imaging during the surgery, which is we have now in common in lots of the hospitals in Ireland, where we can do a spin so we can see three-dimensionally where things are, and that can help accuracy. And finally, the robot would take from that 3D image, and you would basically use the robot as a guide to where you're putting things. So it's not a huge amount more accurate than using 3D imaging and navigation. And there's pros and cons to robots versus 3D imaging and navigation.
Okay.
But certainly all these steps going forward make things a little safer, a little more accurate. But in the kind of, I suppose, it sounds really zany and fantastic, but robots are very different depending on how they're designed and what they're actually doing. But most of the time, what a robot is it's an expensive guidance system for where you're putting the implant in the spine. It's no more, no less. You still actually need to know how to get to the spine, and you need to have the orientation. And the danger with technology is if you start to trust just the technology and you don't know from experience where things are at, if the robot is off by, or the navigation is off by a fraction, you might run into trouble. It's a bit like driving your car and relying on your GPS, but actually if you've driven the road 1,000,000 times, you know, or 100 times, you know the way already, so you don't need your GPS. But the GPS may help you if the weather is bad, or if it's foggy, or if it's dark and your lights are not working perfectly, or something like that. So these things can be useful to make surgery a bit safer, but they're not the full answer. Currently, I don't use a robot, but I do use 3D imaging and navigation routinely, just to even double check that we're happy with everything.
Yeah. So in 20 years' time, it could be just robots and no surgeons. You never know.
Well, you still need the surgeon to operate the robot.
Yeah.
Surgeon to make the plan for the surgery. And in fact, the robot is just used as the guide, so that normally it's just giving you a target for where you're putting the drill in, or the screw, or whatever implant, or where you're making the maneuvers. So it's only doing a component of the procedure, but it may be one of the more accuracy requiring steps, if you know, where you really need to be millimeter accurate as to where you are.
And is that where spinal cord monitoring would come in as well? Like so they didn't have that years ago.
Absolutely. So spinal cord monitoring is something which we use all the time in deformity surgery, and you wouldn't absolutely start an operation without spinal cord monitoring. But we even have refinements within monitoring, so now we can test little areas where we're working to check, yes, absolutely, it's okay, everything's okay with that spot. So we know actually refining, or we're all continually refining what we're doing, using whether it's imaging or electrical monitoring or other steps. Those are all components of what if they're not the same thing, they're part of a picture.
Yeah, it's very interesting.
It is, it's fascinating. And,
it is fascinating.
And like talking to me about it, I'm not a robot specialist, so you get a much more different answer from someone who's a robot specialist or someone who's a monitoring specialist. But I know enough information from them to assimilate what they're telling me to learn how to work with it or not. Yeah.
Okay. I thought you were going to say you'd get a better answer to somebody who is a robot from somebody who is a robot.
Well, robots, I don't know whether robots overtake physiotherapists.
Hopefully not.
Yeah, let's hope not. So will I move on to the next question? This lady, her name is Kim. She had surgery done 10 years ago. no, sorry, 12 years ago. Sorry. She is 12 years post-op, and she lives in the UK now. So she has a balloon-like swelling at the bottom of the left-hand side of her spine, and it comes and goes, and it can be sore sometimes. So she went to see a surgeon over there, because she lives there now, and he said it was an inflamed fascia rubbing between muscle layers, and he said the best option was to remove the rods, because she's now 12 years post-op, so she doesn't know what to do. Is it okay to remove rods 12 years later?
So I suppose from standing back from it, it's a good question. The rods perform their function in the first year or two after surgery. They are there to hold the spine in a new corrected position, and what you're looking for is fusion, which is that the bones will come together and integrate into one structure. So theoretically, if the spine is fully fused, the rods and screws have done their work, and they could be removed if essential. However, it's difficult enough to get them out. Sometimes they can be embedded within the fusion mass, so it's not a small, trivial operation.
Yeah.
And if there's a problem which is changing of late, it sometimes might reflect another issue. So I think that needs to be carefully considered. Is there a lack of fusion, as say at the base of the spine, or a little micro movement going on that is leading to periodic bouts of inflammation? And it sounds to me like this girl may have a bursa, which is a small cyst over a metal or bone prominence. And that cyst can fill up or close down, but it may reflect a bit of micro movement, but it also might just be there because of some prominence of a screw or rod. I would say that typically you wouldn't need to remove the whole implant or all the rods or all the screws, but it would maybe need focal adjustment or treatment. Sometimes it just needs the end of the rod removed if the end is a little prominent and rubbing against the muscle or fascia. Sorry, I know a bit long-winded in my answer.
Yeah, no,
it's difficult to say. I would certainly say I'd be looking at possibly getting a scan to look at the area. I think definitely the person looking at the situation should be a spine deformity specialist,
yeah,
and used to dealing with this. So there are people in the UK who are doing 50 to 100 scoliosis operations a year. That kind of person is the kind of person you want to be talking to.
Yeah.
And I would certainly analyze it a bit further before jumping, making that decision. In all of my years, I'm starting to sound really old now. We've seen one patient who had maybe a bit of an allergy or metal allergy reaction where we removed the rods because of that. Years after surgery, she did fine. And very rarely you might see someone who develops an infection, a late infection after surgery. That would be far less than 1%. So there are possibilities which can be analysed and looked at, but I would say it's not something to be a decision to be made in this kind of context. But we do see sometimes issues like this.
Yeah. So it would be something that she'd have to think long and hard about.
I think any spine situation where you're talking about taking everything out, it'd be very much a careful thought about, considered decision. But I'd have to also say, like in scoliosis surgery, over 90% of people never need a further operation. So the small percentage that might, that's something that we would deal with for me regularly enough, because of course there's a large number of patients done through the years. But someone who has the experience looking at this many times, it's important to be talking to that kind of person. Yeah.
Okay. We've won the last question. And Hallelujah. That is, so what is Schroth and how is it different? I know I would be asked this quite a lot. So what is Schroth? Since the Scoliosis Academy was set up, a few questions have come in to say, so what is Shroff, sorry, and how is it different from normal physio or like normal exercise, or I'd say Neve, yeah.
Don't ask
Pat,
me.
you can have a break.
Well, Shroff is a form of scoliosis specific exercise. So what that means is it's dependent on each individual case. That specialist or the physio who's trained in the Shroff method will analyse the exact type of curve or curves that you have and then develop a specific program based on that information. The exercises themselves are a bit weird. So anybody who's done them, it's one of those things where you really need to experience it to know exactly what it is. But basically, the whole point of it is to create more length in the spine, which then allows you to unlock any areas that might be a little bit stuck, and get more flexibility in different areas. But it's even more than that. It's about training the brain and the body how to work together. So with repetitive movement, in a twisting kind of fashion, or what we call a derotation, you train your brain how your spine should move, and then by doing that over and over and over again with specific breath, with specific positioning, you can teach your body how it should move. And then what we're doing now is taking the basic Shroff method and changing it and bringing it into more functional movement and bring it into each individual sport or exercise that they're prepared to do. The method involves different types of breath, so big, heavy, what I call teenager size, as well as long hissing exhales. So it's a lot to do with the lungs, the diaphragm, the deep core, as well as very specific positioning to create that nice length in the spine, and then creating the strength and the nerve pathways to hopefully get back.
Yeah, and so can Shroff be done before and after surgery?
Yeah, so what we have actually been doing is even the kids who we know who are going for surgery, we've been using the Shroff method to try to improve the flexibility in their curves. And what we know, even with the bigger curves, while it might not reduce the curve or even hold it at what it was in terms of call angle, it can reduce the rate of progression. So if you're going for surgery, it's nice to try to hold back the rate of the curves progressing while also gaining more strength and flexibility in the area. Especially for, like we talked about at the start of the session, for the lumbar curves, so the lower back, to keep it as flexible as possible so that when Pat's operating, he doesn't have to go further down than he hopes when he's planning. And then it's, I suppose traditionally it's been used as a conservative method in line with the bracing, and now that we're using the Redo No brace, it's even better because the method is used in line with the Redo No brace.
Okay.
Can
We lost Deirdre.
Yeah, can't hear now.
Am I here?
Oh, yeah.
You are
sorry.
here.
Yeah. I don't think was that the last question?
It was.
I know there was a one as well, like, or I might have skipped it. What is the difference between bracing and casting?
Okay. So last question.
Yeah.
Last question.
So casting is something we tend to use in the Victorian era.
Okay.
Before when it got invented was back then, and it's been used in scoliosis for hundreds of years. Okay, that was traditional plaster casting.
They're the scary pictures that you see.
Yeah.
Yeah.
So we still use casting, but we tend to now use not plaster, but we tend to use fiberglass and Gore-Tex because that's more child friendly. And we use casting really in the early years with early onset scoliosis, just to try and mold the spine into a straighter shape as it's growing in very young years. And that's a very, very tiny group of patients in the whole spectrum of kids and teenagers who get scoliosis, much smaller, like a single percentage, 1 to 5% or something. We'll try everything we can to avoid surgery. If a child has proven progressive scoliosis, we'll investigate to see if there's a reason for it, which may need to be considered or treated of its own right. If the scoliosis is progressive at a young age, as I said, it can have impact on other things like your lung and chest development, etc. And if the spine is flexible, if you can hold the spine in a straighter position, with external molding, with a cast, we will do that. And typically we do that under general anesthetic in the first instance, but the kids can get very used to it, and sometimes we can do it without anesthetic. if the spine corrects by 50% or more, the casting or bracing will be successful. Okay,
Yeah.
and so we can see that if it's working or not. And we'll use the cast because they're growing very quickly. There's no point in making a brace in a child who's 1 or 2 because they'll have outgrown it within 3 months.
Yeah.
Yeah, they're growing so quickly. So by the time they get to 5, normally the speed of growth slows down. So then we can change from a cast to a brace. And a brace, if you like, is doing the same kind of thing. But it's a thermoplastic device which you can take on and off, which is a big advantage over the cast. So then they can exercise and do the sports more freely. But most kids live in the cast and have no problem with it and get on with playing football or dancing or whatever it is they want to do in the first 5 years. The bracing is typically used then from middle childhood into teenage years. But it's specifically, I suppose, we would use casting and bracing in early onset scoliosis. And the success rates would be a rule of 3s, as I say to the students. About a third of kids will correct. About a third of kids, you'll see a slowdown in the rate of progression, but they may continue to advance in their scoliosis. And about a third of kids don't correct with either in any way. And we need to consider the growing rod surgery or other strategies we were talking about. In the teenagers, there's a group with adolescent scoliosis which presents in your teenage years, so after 10, yeah? And
Yeah.
I suppose in that group, if they have mild scoliosis, which is detected early, and they have a huge amount of growth to come, it is reasonable to consider a brace to try and guide them through the adolescent growth spurt. And bracing and physiotherapy together have been shown to reduce the rate of progression significantly. So about 50% of the kids who are going to end up possibly with surgery don't end up in the surgery treatment
Yeah.
plan, I
Yeah.
suppose. So it's slightly different. The technologies, casting used younger, bracing used really from 5 years of age onwards.
Okay. Thank you. Yeah.
Okay.
You want to say something else, or yeah?
And it just depends on what's causing the scoliosis. So some types of scoliosis are caused by different conditions. So it's not the same for all.
Yeah. And the word idiopathic is still, it's unknown. So
Idiopathic means that you have nothing else wrong, contributing or causing the scoliosis.
Yeah.
So it's just spontaneous, if you like.
Yeah. Okay. I think that's all the questions, is it?
Okay, it's enough.
Yeah, that's enough. Thank you. Thank you both for helping me with this on your day off. So, and happy International Scoliosis Awareness Day.
Yeah, you too. Happy Scoliosis Day.
Thank you so
Thanks,
much.
Dee.
Thanks.